Hello, this is Jennifer Lindquist, and I'm sharing my capstone project with you, raising awareness for colorectal cancer screening and primary care, breaking down the cultural barriers. I'm sharing this with you because I wanted to share the results since you have been kind enough to attend my lunch and learn session in January, and if you hear any strange noises, that is just my little Ingrid here sitting on my lap. So thankfully I have completed the project and I will be graduating in a week with my family health nurse practitioner degree. So the presentation outline is we're going to go over the project objectives, background, theoretical framework, and synthesis of literature, the PICO question that guided the project, organizational assessment that I had to do, design and methodology, scope of project, evaluation, limitations, and implications for practice. So what were the project objectives? I wanted to increase critical access primary care practice providers' knowledge about Somali and Latino populations, barriers to colorectal cancer screening, and facilitators to colorectal cancer screening for Somali and Latino populations. So who is my target population? Well, it's primary care providers. Presently there wasn't any formal education offered at our facility regarding Somali and Hispanic populations besides an employee forum that was offered several years ago about Somali culture. And in regards to how to educate patients, we have had some education about health literacy about 4 years ago in regards to how to educate patients at a level that they understand. So why this site? Our regional critical access facility provides care for a large majority of populations of Latino and Somali groups, but I wanted to find out exactly how many, which I couldn't find out the exact amount, but I was able to get a snapshot of what that looks like by looking at how many patients use interpretive services. And in 2015, I thought over 1,000 patients use interpretive services. In 2014, about 1,400, and the same in 2013. The top two languages used were primarily Somali and Spanish. Looking at the demographic profile of Barron County, there's about 45,000 people. This is data from the U.S. Census Bureau. As I had discussed in my presentation in January, this information may not be fully correct because some of the individuals may be migrant workers, refugees, immigrants. They may not identify as a selected race, may be visiting family on a visa, or just may not participate in the census gathering process. So briefly, I know I've given you some information on the Somali population, the presentation in January, but it is a rapid growing population within the U.S. Between 1999 and 2008, the number of African-born immigrants increased by 142%, with 40% of those being Somali refugees. The U.S. Census Bureau data showed that we have about 407 people identifying as Black or African American, a little over 200 as some other race. I did contact Barron County Public Health, and they put me into contact with the UW Extension, who are working on a community garden needs assessment, and they estimated that there was at least 500 Somali refugees that were not accounted for in Barron County. And additionally, just a little interesting fact here, the number of Somali in Minnesota is over 33,000, with estimates of up to 70,000, primarily around the Twin Cities area due to secondary migration. And our Latino groups are also not properly represented. They are underrepresented in the Census Bureau. After talking with Barron County Public Health, they did have some information regarding Latino farm workers who had applied for food share and badger care services. Again, this is only a piece of the population that we're looking at because this does not include the families that are attached to these individuals or other individuals who simply had not applied for these sources. So because this was an educational project, was for my graduation, for my degree, I had to have a theoretical framework to guide the project and leadership model. So I chose the Iowa model for my theoretical framework because that's an accepted model for quality improvement projects within our system. And secondly, the quantum leadership, I just really like that theory. It builds on the idea of quantum physics, meaning the concept of change is constant, dynamic, and occurs all around and within individuals. So instead of leading with force, manipulation, or combining power with association, a quantum leader leads by instilling empowerment in others. So I felt this was the best way to be a flexible leader while maintaining a vision and hoping for continued growth of the project. So this is a table here of my literature search that I had gathered for searching for colorectal cancer in Somali and Hispanic populations. I also primarily use the university's website with the Synol EBSCOhost database. I use PubMed, and I also use CDC and American Cancer Society and American Gastroenterological Society. From those articles that I have shown as the number of articles used, I had additional articles that were referenced and found from those references. I also needed to decide how I was going to give the education, so I did do a literature search on what would be the most appropriate form of education for providers, and determined to do that PowerPoint that I had done back in January with the pre and post test surveys, along with some compensation, which is why we had some food available. Thinking ahead to any future projects or provider education, I would think that offering the education to go to CMEs would also be a good incentive. So the PICO question that guided my project: will rural primary care practice providers' knowledge and attitudes be affected by an educational intervention on barriers or facilitators to colorectal cancer screening among Somali and Hispanic populations over? So the provider educational intervention, as you were aware, I touched on the cultural background, including just a little bit of information here. As you may remember, that each group was more traditional, not preventative health care. There isn't actually a word for cancer in Somali. And just looking at some of those colon cancer risk factors, being racial and ethnic minority groups at a higher risk for colorectal cancer not being screened, including Latinos having a higher mortality rate, being the second and third most prominent cancer death, with the overall lower 5-year survival rate as well. And then we also talked about the barriers to screening, so lack of knowledge, less years of residency spent in the U.S. meant least likely to be screened, and then some of those facilitators that we had touched on, including increased awareness, increased educational level, provider recommendation, and I also had to do an organizational assessment. So I looked at the current policy to determine if it fit with my project, the mission and values of the organization, and how those lined up with my project, the overall risks and barriers to implementation, and any fiscal consideration. So the current policy, I'm sure you're aware, follows with the American Cancer Society guidelines. It does include African American, Alaska Native, and American Indian natives to be screened beginning at the age of 45. I would push for involvement of other ethnic minority groups as higher risk in needing to be screened for colorectal cancer as well. So the missions: to inspire hope and contribute to health and well-being by providing the best care to every patient through integrated clinical practice, education, and research. So I felt that using evidence-based education by enhancing knowledge about Somali and Hispanic patients and the risks with colorectal cancer and screening aligned with this, as well as the primary value of the needs of the patient come first. So we need education that was culturally sensitive and conducive for providers to effectively support this primary value. Risks: there weren't really any risks in offering a provider education. Barriers mostly involved the overall size of the overarching organization and trying to implement system-wide education, and then just the small number of attendees to the actual presentation, the lunch and learn. But I am grateful that you did attend. Fiscal considerations were primarily just my time. Design and methodology scope of project. So as you are aware, I conducted 2 learning sessions and had pre-test, post-test, and 1-month follow-up surveys. I used a survey that had already been created for a study which involved education for providers in tobacco cessation and educational interventions that they use for their patients. So even though it was about tobacco cessation, it aligned with my project because it was in regards to provider education. I collected the data at the sessions and looked at the outcomes to determine if knowledge increase and attitudes change regarding colorectal cancer screening facilitators and barriers for Somali and Latino groups, as well as created an overall timeline projecting about 6 to 10 months, which is about how long it took me to complete, and then doing that cost analysis that I had discussed. Next, for the overall evaluation of the project, I had to actually implement the project. Then I looked at demographics, did some data analysis with both quantitative and qualitative outcomes based off of the surveys that I had used, and also conducted a presentation evaluation to see if it. So demographics, there were a total of 10 people that attended, 3 in the morning session. It wasn't very good weather, which I'm sure was a barrier, and the video conferencing was not working in the morning, much to our avail. And there were 3 MDs, 3 RNs, and 2 PAs, and unfortunately there were not any NPs that attended. I also had primarily, my initial focus was with primary care. Interestingly enough, only 3 of the providers were in primary care, and 7 were also in specialty. Looking at the quantitative data results here, as you can see on the graph in front of you, I looked at the level of motivation for recommendation for screening using the Likert scale for these questions, and all providers initially and 1 month follow-up rated the importance between 8 and 10, which was great. I had 7 responses for the 1 month follow-up survey. One participant didn't feel appropriate with the 1 month follow-up survey since they don't actually do patient care. And then just looking at the importance of providing education for Somali patients or Latino patients, both rated were 6 out of 7 of the participants rated between 9 and 10 as high, so being as highly important. So 86% felt it was important after the intervention. I also had open-ended questions to look at qualitative themes and to look at the facilitators and barriers that were felt to be encountered by the providers. Those primarily being education as a facilitator. Language communication was very commonly listed, common theme for a barrier, with interpreters and translators as the best facilitator for this. Cultural diversity, gender, explaining that female Somali patients usually prefer a female provider. A barrier being healthcare access itself and the ability to reach these people. And then another common theme was just screening and some providers not being aware that this is a group that's being missed. And again, the presentation evaluation, so I just wanted to know how I could share this information with you guys, and based on that I thought I would create this voiceover PowerPoint so that you could listen to it at your leisure. Limitations, as we have already discussed, primarily those local barriers is just the number of attendees to the presentation itself. I had shared information about my presentation prior at a physician meeting in November, and system-wide barriers being trying to implement this education across the system. I have been in contact with the compliance department who are considering. I have suggested to use of my PowerPoint that I presented in January as a cultural diversity education that could even be shared like as a link on our intranet or possibly as a CBT, and I'm waiting to hear back on that. So implications for practice. So what does this mean and why is it important? Looking at practice in general, recommendations for the organization, why it's important for health policy, and what does it mean for leadership. So for practice in general, it's cultural diverse education for providers that are going to be using this education, that are taking care of these patients specifically. Also the need for patient education and communication that's culturally diverse, and understanding communication breakdown, using educational tools at an appropriate literacy level, increasing that patient-physician dialogue, and just increasing the knowledge about rationale for preventative cancer services with these patients. Physician recommendation has been shown to be the highest, most important facilitator influencing patient decisions about colorectal cancer screening, so really it needs to be a top priority. for minority groups because of the high indication with healthcare provider recommendation. And then collaborating with the community and looking for those individuals that are highly respected within the community and working with those members to get the message out while promoting healthcare that's culturally sensitive. So for the organization, I'd recommend continued use of those tools that we already have with the flagging system on the EMR for when people need colonoscopies, reinforcing those concepts of health literacy, collaborating with the community, so building on those relationships and reinforcing with those individuals within the community, as well as those programs that we already have set up, like through Barron County Thrive, creating a possible CBT to share the education, creating pamphlets that are culturally appropriate, so having patient education that actually will reach the patients that need it, and updating the policy to reflect and just looking at health policy and leadership. So, it's our responsibility to obtain, create, and share information with patients that's valid, understood, and able to be interpreted in order to improve better healthcare outcomes for patients. American Medical Association and U.S. Department of Health and Human Services show that people who suffer from varying levels of health literacy limitations experience up to 4 times greater cost in medical expenses, and people with lower levels of health literacy are also more susceptible to readmissions and are more vulnerable to health disparities. So it's our job to decrease these health disparities for these susceptible populations. That was the purpose of this project, is to share this information. And we are a culturally diverse world. We are becoming more culturally diverse within even our little community. So we really need to be aware of that and embrace that and meet the patients where they are and who they are, regardless of culture, and just planting the seed. So getting that information out there, if it's not going to happen today, maybe they will start talking about it, or just increasing awareness about cancer itself. And then just using that theory of quantum leadership, so empowering others and empowering each other, empowering the patients, and being a patient advocate was also really brought to light through this project as well. So thank you so much for listening to my capstone presentation. I tried to shorten it up. I know it's still kind of long, but if you made it through, really thank you very much. If you have any questions, you certainly can email me or contact me. I have no issue with that, and then I also have included my references at the end of this presentation. So thank you so much.